Many patients get IVF done nowadays, many succeed and many don't. IVF failure is a gut-wrenching process. It is an emotionally draining process. It is very hard for a couple to take. Both of them, husband and wife, undergo a gamut of emotions from sorrow, hollowness, sadness, despair, depression. And as a fertility caregiver, as a fertility doctor, it is very important for us to thoroughly evaluate the case of IVF failure. First thing which comes to the mind of a female when she who has undergone the IVF does not succeed, why did my IVF fail? What have I done wrong so that my IVF did not succeed? What could I have done differently? Did I eat that thing which was not good, or did I do that thing? Did I not do enough rest? These are the gamut of questions which the female and the couple undergo. So today we will be discussing this topic, IVF failure, which is very close to my heart. Good morning, I am Dr. Rajat, with me Dr. Sapna. We are consultant gynecologist and infertility specialist from Matrut Hospital, Vadodara, and you started seeing our YouTube channel, Gynek Didi and Gynek Wala. Sapna, IVF failure is very common in our OPD nowadays. A patient who has undergone an IVF and her beta HCG is not normal or not positive, it is less than 5, and she gives you a call on phone, "Ke madam, my IVF is failed." What will you tell her on phone?
Yes. So very rightly you have said that IVF procedures have become very common nowadays, and this type of scenarios are also very common. And now patient has called me informing her beta HCG report, which is not good and which says that IVF has failed. So not only it is disheartening for the patient, but it is disheartening for the consultant and the IVF specialist also. Because couples as well as the doctor, the entire team is working for the case, working for the patient, for the success of the patient. So first of all, yes, there is a failure. We have to inform the patient, yes, the report is not good and mostly it is negative and she has not conceived. So we have to pass on the correct message to her. We cannot give her false hopes. Second, we have to counsel her at the same time. We have to understand her emotions. I'll be explaining her, yes, it is negative. Now you calm down. You stay with your family. Inform your parents, inform your relatives, your close family relatives, and pray to the God and relax. And come and meet me anytime whenever you are mentally prepared. If they want to immediately come and meet me also, then also I will not be discussing here the causes of failure. I'll be just counseling her, calming her, giving her reassurance that there is a chance in future also. But overall, we have to counsel her a lot, and we have to understand her emotions and her husband's emotions.
IVF failure is very emotionally challenging, mainly for the patient but for us consultants also. But what we tell to our patients, IVF failure is not the end of her fertility journey. It does not mean that she cannot become mother again, that her husband cannot become father again. Yes, it is the end of that hope for that particular cycle. She has undergone lots of emotional trauma, lots of leaves from office, lots of injections, invested lots of time and money in her IVF. And once when you are given a hope that yes, there is a hope for a child, and that hope vanishes, then you fall, you are crestfallen, you are emotionally very down. But first thing we will tell, okay, please take some time off, stop everything, and meet us in after 7 to 10 days once when you are emotionally relatively relaxed. Because if we start counseling on that very particular day or on next day, they may not be in a positive state of mind to absorb what we are telling. So what are the emotional aspects the couple undergo in case of an IVF failure? What have you personally seen in your patients?
Yes, because IVF is associated with lot of hope. And mostly the females or couples who are going for IVF, they are going in a little elder age group. They have tried all methods of conception, the numerous ovulatory cycles, induction cycles, maybe IUI procedures, maybe laparoscopy, hysteroscopy. So after going through all this, when some couple is going through an IVF, they have like entire hope in that this time we are going to make it. And suddenly when there is a negative news, so it is very difficult to absorb. So mostly the female partners, they are like totally sad, there is a lot of anxiety, hopelessness, kind of guilty feeling is also there. Ki, what is happening to me? Why with me? And what I have done that it is happening again and again to me.
See, there occurs a sense of guilt, there is a low self-esteem. It is kind of a bereavement, as if somebody has expired in the family. The sense is emotionally, the same feeling is kind of a bereavement. So yes, for us, there has to be a professional setup. First of all, we do not stigmatize the infertility. We have to individualize the case. We have to tell her that nothing, it is not the end of the world. It is not end of life. Yes, there is a life, and with every sunset comes a sunrise. So please hope for the best, and we will do better next time. There has to be a structured closure for an IVF failure. What do I mean by structured closure? If an IVF fails, that doesn't mean you throw off all the files and you stop doing everything. You sit with your infertility specialist after a while, week, 10 days, 15 days, month, whenever you are ready. Evaluate all the causes, what was done, what were the reports, what could have been done better, and what should be done next time if you do plan to go for an IVF next time. So a structured evaluation is very, very important. Over next 4 segments, what we are going to discuss is some questions related to the IVF failure, how will we evaluate and investigate a case of a IVF failure, and what can we do possibly next time so that the IVF does not fail. So Sapna, I'll ask certain questions. These are short questions and we need short answers.
Right.
So what happens in a body of a female who has just failed an IVF?
We are talking about it like she is very, very sad, depressed, and totally emotionally involved, guilty feeling.
Her first question would be the embryos were of good quality, why it failed, what are the most common causes of 4-5 most common causes which can come to your mind?
See, here we have to assess the patient step by step.
Okay.
Even though it was a good cycle, good embryo, day 5 embryo, good endometrium, everything was well planned. But again, we have to understand that it is the chances of success is 30 to 50%. It is not 100%. So we have to counsel. Even before the start of the procedure also, mostly we counsel them. But this fact has to be accepted.
See, autoimmune disorders, blood pressure, hypertension, history of any thyroid disease, diabetes, these are the most common causes of IVF failure. So generally you said 30 to 50% chances of IVF success are there. So does it mean that if she undergoes a second try, the chances of success may improve?
Yes, definitely. Chances of success will improve definitely if we assess this cycle. If we assess and try to find out the causes of IVF failure. With the doctor, the couple has to sit with the doctor. They have to assess each thing and they have to correct this.
You said earlier that the females or the couples who are undergoing IVF are slightly of an older age. So does that mean that female age plays a very, very important part in IVF success? Or in other words, should they undergo IVF relatively early in their reproductive age?
Yes. Now very most common factor now we have started is like age. The age of the female is very important because here we are talking about their eggs. And it is a known factor that after 30, the quality of eggs and the number of eggs, they reduces drastically. And once the limit of crossing is done, then again the success rate decreases. So it is very important to plan the IVF cycles early according to the case, and sometimes even the couples, they are not interested. Mostly it is not, doctors are always advising. We know when we are giving them early treatment, we know that how their eggs are forming, whether they are forming eggs or not, whether response is coming or not. As a infertility specialist, we know that in normal patients also how the response is there. And time to time we are counseling them that if they don't get results, they may need a IVF. So we are already telling them all this.
See, AMH is a very good concept which has come by leaps and bounds in last 15-20 years. Earlier we were not doing AMH, but we have now, since last 5-10 years, we have started doing AMH in each and every patient, and it gives us a sense when to go for an IVF or when to advise the patient to go for an IVF. it is better to go for IVF when our eggs quality are in a relatively better shape rather than as a last resort for a fertility treatment. What I explain to my patients in my infertility, AMH is an ovarian reserve and it is like a popcorn which we eat in our movie theaters. The popcorns which are on the top, they are of good quality. Every popcorn is good, but as we go down, as the popcorn seems to be ending, the quality of bad popcorns are relatively more compared to the good quality popcorns. Same is with the ovarian eggs. The moment the female is young, the quality of eggs are better, and as she ages, the bad quality eggs become more in number, and the quality of embryos become bad with advancing age. So once IVF has failed, when she is expected to get her periods?
Within 8 to 15 days. It varies person to person, but 10 to 15 days she will get her periods.
After embryo transfer, if some female has got spotting or bleeding episode, does that indicate that this cycle is going to fail always?
No, not necessary always. But if there is a difficult transfer, she is having spotting, then we will not be very sure about the success rate.
If her IVF has failed, how soon can she go for a second cycle if she wishes?
Yes. For a second cycle, she has to first normalize, because there is a sudden shock right now. And all this hopelessness and despair and sadness, this mental state of the female can affect the implantation of the pregnancy. So let her calm down, maybe 4 to 6 months, maybe in the 1 month or 2 months. That would be a good time, provided how she is feeling.
Okay. So if during counseling, what will you tell if she asks, can we do something extra, or are there any other advanced techniques to improve the result of her IVF next time?
Right. Now here we can take two cases that already the embryos are reserved. Embryos are already preserved and they have to go and plan for the second cycle. So that is a different scenario, and there is a scenario where there are no preserved embryos and now they have to go for a fresh new cycle. So for a fresh new cycle, we have some different technologies coming up like PGTA, like pre-implantation genetic testing for aneuploidies. This is a test which can be tested on the embryos to find out the quality of the embryos and the aneuploidy if it is there. That may be one of the reason for implantation failure. And second thing is we can assess the endometrium receptivity, and that is like ERA, endometrial receptivity array, which can be planned for difficult cases, the autoimmune cases, maybe recurrent failure cases. This can be planned to find out the window of embryo transfer.
One of a very famous and senior IVF doctor just few days ago told me, ગુજરાતીમાં I'll say, IVF embryo બનાવવાના અને ચોંટાડવાનું રમત છે. In English, if I may transfer, IVF is the game of making embryos and getting them stick. So embryos, what is simple seed and soil theory? If seed is good, soil is good, then there is a good quality harvest would be there. In IVF, the seed is embryo, soil is endometrium. For seed, we would do a PGTA to get to know whether they are a chromosomally absolutely good quality embryos. And for soil, for endometrium, we would do something called, she said, ERA, endometrial receptivity array. So, any role of stress in IVF success?
Yes, definitely. If patient is too anxious, too much in stress, working a lot, all these things in subconscious level, it affects the body in an overall way.
Any role of diet, lifestyle, which we can tell her next time to do?
Yes. Diet, lifestyle, weight management, stress management, anti-inflammatory diet. Yes, everything has a role. Even for a normal female who want to get pregnant naturally also, all these things are very, very important. That we are already counseling them and already we are insisting them to follow all these things.
So, now that we have talked to the patient on phone, first of all, before the patient comes to us, we will discuss what can be the possible causes of an IVF failure in that particular patient. That causes can be divided into the pre-treatment part and the treatment part. Right. So, please enumerate what can be the pre-treatment causes of an IVF failure.
Yeah. Pre-treatment, like we can always say that what is the age of the couple.
Okay.
Here I'm talking about couple, because the female partner age we have been speaking so much in detail that AMH get affected, the eggs get affected. But if the partner, the husband age is like more than 45 or somewhere like elderly age group, their quality of sperm is also decreasing. So are we giving adequate supplements and antioxidants to the male partner? We have to assess that. How is his lifestyle? Whether he is tobacco, any chewing, any smoking, alcoholism, obesity, sedentary lifestyle, all these things we have to assess in him also. So this can be, the age can be a factor which has to be assessed for both the partners. For female we have to do for the counseling part, and for the male we have to go in depth detail what he is doing, and we have to add on, and maybe we can do some tests to find out if anything extra medicines to be done. Second thing is their body mass index. Here, not only female, even for male also, the body mass index, the obesity, at what level of obesity is there or underweight is there, because all this is a game of hormones. Okay. If there is happy hormones, harmony of hormones, obviously there will be good quality eggs, and again when we go for implantation, the chance of implantation is going to be very high. So we have to assess for their body mass index. Next we have to find out the cause of infertility, that all these years they were not able to conceive, and what was the most common cause of infertility, whether it was male factor, whether it was tubal factor, whether it was like endometrial factor or some autoimmune or hormonal problem. All these things we have to assess. Again, AMH levels we are talking about, day 3 scan, the antral follicle count, that is important, and what is their lifestyle, any occupational hazards are there, like some males they are working in chemical factories or heat, where the heat is more. All these things we have to assess. What you want to add?
See, like she said, for male partner, tobacco smoking, alcohol, obesity, most of the patients who come to me, sir, we smoke tobacco, we smoke cigarette, okay, yes, we are obese, yes, but our reports are normal. Right. What I tell to them, just because your counts and motility are normal, that does not mean that the quality of sperms are also good. Ultimately, what this alcohol, smoking and obesity do, they act at a molecular level, and the quality of DNA gets little bit deranged, and that is why the chances of failure do increase. So what we'll do next is we'll get a sperm DNA fragmentation index for that male that will tell us how much quality of good sperms he has. Now the question is, if there is a bad DNA sperm fragmentation index report, can it be reversed? Answer is yes, it can be reversed with a good quality lifestyle, abstinence from tobacco, alcohol, smoking in any form, and after 3 months, 4 months, 5 months, the chances of getting good sperm in the reports are better. So these were the pre-treatment factors which can be modified. What are the treatment factors as far as the monitoring, the induction aspect is concerned? Kindly enumerate those factors which we look at.
Yes. So the most commonly we have to see that what kind of protocol was used for IVF. The stimulation protocol we are talking about, and how was the response of the patient. Like whatever doses of injections we have stimulated, how were the eggs formed, and what is the endometrium we got. All those things we have to see. So the protocol is important. Then we have to also assess other immunological factors if the female has, like if she has any endometriosis, whether the laparoscopy and hysteroscopy was earlier done or not. Any autoimmune disorders like hyperthyroidism or hypothyroidism, any other hormones like prolactin disorders, hyperprolactinemia. So hormonal factor we have to find out. Obesity already we have talked. Then we have to assess the tubal factor, whether her tubes are analyzed or assessed before, maybe with HS-graphy like hysterosalpingography or saline sonography, which showed Hydosalpinx in that. Because if it is there, before next IVF transfer, we have to correct each and every factor here one by one.
See, it is wonderful that you enumerated these factors, but what I have practically seen in our practice, that most of the patients who get IVF done from somewhere else and who come to us, usually they don't have these reports, what protocol was followed, how many follicles were formed, how many embryos were formed, how many embryos were transferred, what was the endometrium at the time of transfer. So usually they keep all those things with them, and the patients are not given any papers. No fault of the IVF center. I am just telling this is what happens practically. So these are the things which we discuss. Now patient comes to us. We will sit with them with their file and we will start evaluating what can be done. Point by point. What do we see in those files? What about the embryo? I'll take 1 point each. What about the embryo?
Yes, what was the transfer? Again, in the embryo transfer, we have to see whether it was day 3 transfer, day 5 transfer. Here, I would like to highlight that here we are considering that this is our own cycle, which has got failed. And we know that patient is with us and patient has come us to...
Just for our viewers, please tell what is day 3 transfer and what is day 5 transfer. When do we call it as day 3? Day 3 from when?
Right. So day 3 transfer is like the day we start the progesterone injections. And we transfer, once the embryo pickup is done and you fertilize,
that is day 0.
Yeah, once the day the pickup is done and we fertilize the ova with the sperms and we wait for the embryo to grow, for the best embryo to grow. So that is day 3 and day 5 transfer. It is usually said that earlier it was day 3 transfer and nowadays it is like day 5 transfer. Mostly the IVF specialists are preferring.
Day 5 is called as blastocyst. Most of the embryos which grow up to the blastocyst stage are presumed to be of very, very good quality, both chromosomally and otherwise. Earlier, about 5-10 years back, we used to do day 3 cleavage state transfer, but 50% of day 3 embryos, they usually do not reach up to the day 5. So if they cannot reach day 5 in laboratory, that means they won't be able to reach day 5 in the uterus also. So presuming this, nowadays most of the IVF centers are going in for a day 5 transfer. So if we transfer only one embryo, what are the chances of success for IVF? Or if we transfer 2 or if we transfer 3, does that mean that there would be more chances of success?
As your question is like single embryo transfer, in single embryo transfer the success rate is like 30 to 50%, or maybe you can say 30%, and then we can otherwise say like there is a chance of 70% failure is also there. And if we do double embryo transfer, again there are no research or studies done, but mostly it's like 50-50 we can understand.
We have seen the embryo. Now comes the next most important point you have discussed last time before before also earlier in the video. Maternal age. Kindly discuss in detail why we emphasize so much on the maternal age and what is the difference between a chronological age and a ovarian age, and why Indian females have got less time compared to their European or American counterparts.
Right. So this is a wonderful question, and one of the most common reasons for infertility also is like female age and the maternal age, right? So when a female baby is born, she is born with a fixed genetic load of eggs, which is fixed and it will not change in her life once she is born. And the moment she attains puberty, these eggs, they start getting ovulating. She starts ovulating eggs every cycle and her egg starts reducing. Now maybe like when she is born and when the puberty starts, she has around 4 to 5 lakhs eggs. That's the fixed amount she has. And now once the eggs which are getting destructed each cycle after 30 years of age, this phenomenon is happening very rapidly and very fast. Therefore around 29, 28 or 30 years of age, she is destroying her eggs at a very faster rate. And if she has autoimmune processes like endometriosis or thyroid, prolactin, any kind of PCOS, these kind of problems are there, then again these factors will again cause the rapid destruction of her eggs. So she is reducing her eggs fastly, and nowadays people are planning pregnancies also very late because of their profession, career and studies, getting marriage also late also. So these are the most common reasons. And according to our classification, if we see, whenever we decide a stimulation protocol for a IVF case, according to our classification, we have the age criteria, and when we use the amount of maybe follicle stimulating hormone which we are using, as the age increases and AMH falls, the amount of follicle stimulating hormone which is required to stimulate the eggs, that dose also increases, and once you increase the dose, again it will have side effects on the endometrium and the implantation.
So you said around 30 the number of eggs start decreasing. In India that age is about 2 years earlier. So about 28 the eggs start decreasing, which we have seen in our practice. So would you advise females to undergo IVF relatively at an earlier age? It is an ideal world scenario, not a practical world scenario. In an ideal world, would you say if females are thinking maybe 6 months, 1 year later we will go IVF, for IVF it is better to go for IVF relatively early rather than late? Is it a right statement to make?
See, here in my patients, what I will do is I will do an AMH.
Okay.
Because suppose if they are planning to plan pregnancy after 3 years, she should know where she is standing here right now. So I will take a one simple test, blood test, anti-Mullerian hormone. That will guide us to where she is standing. Suppose she is having somewhere like 3.5, 4 or 2.5 or 3. This indicates a very good AMH, right? So we can counsel her that she has good quality of eggs right now. Maybe she should not postpone a lot, but she can think about maybe 6 years, 6 months or 1 year.
Hold on. You said AMH of 3.5. Now, does that mean AMH of 3.5 in a 26-year-old female and AMH of 3.5 in a 34-year-old female, they both have got decent chances?
See, here we are considering an average female of 28 or 30.
Okay.
Because see, what is happening is people are married, but now they have to study, maybe they have to work. So they want to postpone their planning of pregnancies. So we have to counsel them decently. Right, we have to give them average, like we just can't say ki now your AMH will reduce, you can't plan right now, you have to plan right now, you have to study after. We cannot say like that. So we have to give them a genuine thing for their age. So let us consider a female of 30 years, and if she has a good AMH, maybe we can counsel her that maybe she can delay 1 or 2 years, not more than that. That's how we can counsel. But anybody who is like 33, 34 or 35, we will not ask her to delay at all, whatever is her AMH is, because her age is also increasing. Even if she conceives, she has her maternal morbidity, maternal causes which will affect her pregnancies also.
Also, age decreases the implantation rate in the uterus also. So, does that bring oocyte cryopreservation or oocyte freezing into picture somewhere?
Yes, it is very common with the celebrities postponing their marriages. Again, somebody is going for chemotherapy or radiotherapy for any kind of cancer treatments. So it is commonly seen and is done for them.
Okay. So we have discussed age. Now comes next very, very important point, obesity or the body mass index. Both males and females. Go for females first.
Yeah. Females, see, if she is suffering from PCOS, classical PCOS, obesity, irregular periods, even if she has a good AMH, she is not conceiving because her body mass index, so she has to reduce that weight. And it is known fact that 10% reduction of body weight makes her naturally conceive. So there is a good chances of spontaneous conception, and even if she is going for an IVF cycle, we will get good response and at the same time good implantation rate, because research studies have shown that obesity is also one of the factor for implantation failure.
You discuss about obesity. What about the low weight? If her BMI is less than 20, would that affect the success also?
Definitely, because if we understand in this way, for a normal menstrual cycle, female needs at least 22% fat in her body. And if she is low body mass index means anybody who is less than 18. So if she has body mass index is a formula which we use to calculate with the weight and height ratio. And if she has less than 18, it means the percentage of fat in her body is very less. And when fat percentage is less, hormones are not proper, not in adequate amount, because all these hormones, they are formed by cholesterol. Good cholesterol I am talking about. Here we are talking about healthy fat only. We are not talking about bad eating and bad fat.
Obesity or high BMI in any form affects the quality of oocytes, the quality of sperms in males. It affects the chances of implantation. It affects the miscarriage rate also. So it is better before she opts for an IVF, she comes to relatively normal BMI range. Now, coming to the next point, the uterine factor, which is very, very important. Discuss about those factors. What can we see? How to evaluate those factors?
Here, if there is, now we are going to uterus. So in uterus, whether earlier any 3D sonography is done, any HSgraphy, hysterosalpingography or saline sonography or any hysterolaparoscopy was done earlier or not. Because here we want to look at the size of the cavity, if there is any different shape of the uterus like unicornuate, bicornuate. Yes, we can pick few things in normal sonography. But before going for a failure case, we have to again reassess whether there is a septum which is sitting there, which is one of the reason for the failure of the implantation.
What happens if there is a septum? Why it fails? Why implantation, if it occurs on septum, fails?
Because septum is like a projection from the uterine wall. Again, the vascularity is not good, and if the implantation happens at the septum, the pregnancy will not get adequate vascularity and nutrition, and there tends to be implantation failure.
Okay. What else?
Yes. So we talked about uterine cavity, the size of the uterus, all these things we have to assess. Why I am talking this step by step, because here for everything there is a cost thing. If already the patient has undergone HSgraphy, we can ask her to bring that plate and show it to us again. If there is a laparoscopy done already, we can see those videos or photographs which was done earlier to assess, really find out if there is a septum seen in, if there was a removal done or not done that time, if there is a Hydosalpinx in the tube. All these things we have to address.
What else in the uterus apart from septum?
Any fibroids.
What exactly about fibroids? Where they
Yes.
are? The size of the fibroids?
Fibroids can be of various types, but the fibroids which are sitting inside the wall of the uterus or in the endometrium, intramural fibroids and the submucous fibroids, they can potentially lead to implantation failures.
Anybody who must have done IVF before may have ruled out this kind of thing.
Yes.
Suppose there is a about 2-3 centimeter intramyometrial fibroid, intramural fibroid, not disturbing the cavity. Would you kind of think of removing that fibroid before undergoing IVF next time?
Again, this is a controversial thing, because here if we go for a small 2 or 3 centimeter removal of the fibroid, we might be injuring the wall of the uterus also, and that might also has its own complications. So we have to assess the case in toto, and we have to see that what is happening and how is her previous histories, whether she has earlier abortions, any history of earlier abortion is there. Maybe she has conceived naturally once or twice and she was aborting, and history of previous abortions are there, then in that case probably we have to remove that fibroid. And when maybe there is a difficulty in embryo transfer, that time if there are difficulties, then maybe we have to think about it.
There can be polyps also inside the uterus. There can be the swelling of uterus, which we in our language call as adenomyosis. These all factors are related to the uterine factors. Now we come to the tubal factors. You have discussed HSG. Hydosalpinx is there. Now does and how that Hydosalpinx affect our embryo transfer?
Hydosalpinx means tube, and hydro means water. So there is a collection of water in the tube, as you can see from this figure. So this is the uterus, and here we are talking about uterine cavity, and these are the fallopian tubes. In a IVF procedure, we don't need fallopian tubes, because everything is going outside. It's like a test tube baby. But if there is a Hydosalpinx, what will happen? This collection of fluid can enter the uterine cavity, and when we transfer embryo, this can be like harmful for the endometrial environment. So it can lead to implantation failure. So if there is a proven Hydosalpinx and if there is an implantation failure, next time before transferring the embryo transfer, we have to remove these tubes by laparoscopic method.
See, we want embryo to stick inside the endometrium. In Hydosalpinx, what happens is the fluid from the fallopian tube continuously comes back and drips into the endometrium. Now it is a very simple science. If we want to stick on a wet surface, anything won't stick. So we want a dry surface to be there. So if the fluid continuously keeps on dripping from the Hydosalpinx towards the endometrial cavity, embryo may not stick. So we have to remove that source of fluid, or in other words, either we have to clip the fallopian tube so that the fluid does not come, or we have to remove the Hydosalpinx so that the fluid does not come back again. So any role of a trial or a mock embryo transfer?
Yes. Many IVF specialists, especially in the cases of IVF failures or recurrent failures, they are going for trial ET. Trial ET means actually before actual embryo transfer, they want to put the patient in position. They want to insert some embryo catheters and see whether the passage of that passage is correct, or there is any cervical stenosis, or there is any difficulty in transferring the embryo.
See, not all embryo transfers are same. Not every patient is same. Not every patient every time is same. So while doing a trial embryo transfer, what we see, at what distension of bladder does uterus become straight, how much traction do we have to give, how much lithotomy do we have to give, whether there is a easy transfer or whether there is a difficult transfer, whether the cannula goes inside easily, at what distance till the fundus, the embryo transfer catheter goes, at what level we have to withdraw, is there blood on the tip during the transfer, or do we have to use a rigid catheter or before and then insert a soft catheter. All these things we get to know while doing a mock transfer, so that while doing a actual embryo transfer we are not having difficulty to go for a transfer. So any role of a irrigation of cervical mucus before embryo transfer?
It can be done. Many are doing because it will remove the excess some mucus, and we remove the mucus plug. What do you say?
Some say it can be done, some say it should not be done, some say there is a bacteria inside the mucus, so it is better to remove. Depends upon the IVF specialist. The most important topic of the failure, IVF failure, frozen versus fresh. What do you say?
Nowadays, mostly IVF specialists are going for freeze all cycle. That's how we call it. And in a way, if we try to understand, it is a good way, because here, when we are stimulating, we are using higher doses of follicle stimulating hormone levels, which disturbs the endometrium. So our endometrium is not synchronous with the hormones. So when we freeze all and we transfer in the next cycle, everything is under our control.
Nowadays, frozen is the answer. We do not do fresh cycle in most of the cases. So, suppose patient has gone multiple endometrial biopsies, multiple DNCs, multiple curetages, or during her previous delivery, she may have undergone postpartum hemorrhage for which DNC was done, and she is having thin endometrium in this cycle. Is it a cause of a failure? What can be done for increasing the endometrial thickness?
Yes, thin endometrium is one of the major causes of failure. It is a challenge for IVF specialists to form a good endometrium. And even actually starting IVF also, some people are actually, they give estrogen and see whether they are forming endometrium or not. So again, there are multiple medicines are available. Like you have...
First of all, for our viewers' discretion, tell us what is thin endometrium, what do we call it as a good endometrium, how much?
Endometrium is actually the thickness of the lining of the uterus that we are talking about. Again, from beginning, we are talking about the soil and the seed. So here endometrium is our soil, and we want a good thickened soil for a good implantation.
How much thick?
Yes, anything which is like more than 7 millimeters, like 7 to 8 millimeters is something very good, and anything which is less than 5 or 6 millimeters is less.
Okay, so what are the medicines?
Yes, so we have multiple medicines available, like arginine is a component which is available in the tablet form or sachet form, which can be given to increase the supply of the uterus and to increase a good endometrium. Then we have like sildenafil kind of tablets are vaginally can be prescribed, and pentoxifylline, antioxidants like vitamin E. What you will add?
See, endometrium is formed by the estradiol hormone. Usually everybody gives estradiol hormone, but for estradiol hormone to reach the uterus, it needs the vascularity. It goes from the uterine artery to the radial artery to the spiral arterioles, and then it reaches the endometrium. So if the vascularity is not good, it may not reach the endometrium, and endometrium may not form, or in some cases of excessive curettage, the basal layer of endometrium may have been damaged, and as a result the endometrium may not form. Or in past history of severe tuberculosis of uterus, the endometrium may not form. But still certain supplements, like she mentioned, vaginal sildenafil, low dose aspirin, or L-arginine, vitamin E, pentoxifylline, all these at some or the other way they act to improve the endometrium. Recently, in last few years, granulocyte colony stimulating factor GCSF has also come, and all these in some or other way they increase the endometrium by 1 or 2 millimeter. But most of the thing, the chances of a thin endometrium, which in our practice we have found, is a low vascular supply. That means high uterine artery resistance, and we have to deal with that thing. So after the endometrium, the ovarian induction protocol we have discussed, the luteal phase support we have discussed. Now we come for a investigation before the next cycle. What are the blood tests we will do for that patient?
See, already the blood tests are done. For the female partner, we can do DNA fragmentation test.
Sperm DNA fragmentation
Yes,
test.
that is done in the sperms for the semen parameters we are doing, right? And for the female, we can do some autoimmune profile panel can be done
Okay.
to find out that, and we can do some antibodies like beta glycoprotein antibodies. In fact, very IVF specialists routinely before the first IVF also they are doing anti-cardiolipin antibodies. So all these autoimmune factor we want to assess if it is there. And before now, if suppose embryos are preserved and we want to go for frozen transfer, so we can go for ERA, which we already spoke, that is endometrial receptor
There are 5 embryos remaining.
Right.
Would you do anything on embryos?
Yes.
Which test would you do on the
Yeah,
embryos?
we already mentioned in the video the PGT A.
Okay.
That is, it is like taking a biopsy from the embryo and to find out the aneuploidy if it is there, and if it is there, we have to discard that embryo, we have to avoid that embryo, then we have to check on the next embryo. So before that, the PGT is important and ERA is important. These two things can be done. ERA is again a full procedure which has to be done in a one complete cycle. And would you explain it how it's done?
For seed, we do PGT, and for soil, we do ERA. Usually, we do ERA after 2 or 3 IVF failures, not before that. But PGTA we can do next cycle. Suppose it is a frozen cycle and we have got 4, 5, 6 embryos left, then we can start doing PGTA from one embryo. We don't do PGTA for all the embryos. We do it in one embryo. If it is good, then we transfer that embryo. If cycle fails, then again we do PGT, then again we do. For ERA, ERA is endometrial receptivity array. We start the cycle as a frozen embryo transfer cycle. We give estradiol, we see the endometrium building. Once the endometrium goes up to 8 or 9 millimeter, we start progesterone. The moment we start progesterone, our implantation window has started in any form. Whether progesterone is in capsule, dydrogesterone has been given, or injectable progesterone has been given. Day 5 or day 6 of progesterone, we take an endometrial biopsy and send it for the molecular genetic analysis, and that analysis gives us the report that at what hours, it gives us a range 105 to 110 hours or 110 to 120 hours. After starting the progesterone, you have to transfer the embryo. So in next cycle, when we are planning a frozen embryo transfer cycle, once we have started estradiol, then we start progesterone. The moment we start progesterone, whatever range has been given in our ERA report, that range we have to follow, and within those hours of that range, we have to transfer the embryo, and that increases the chances of success in the next cycle. Any role of karyotype, parental karyotype in a case of an IVF failure?
Parental karyotype can be done and should be done because it is a simple blood test for both the partners we can do, and we can to find out and rule out any genetic problems or any chromosomal issues are there.
Suppose in a female there are certain chromosomal issues. So would you advise that female to go for a IVF next cycle with her own eggs or something else?
It all depends on what kind of chromosomal issues are there.
Okay.
And there are cases of thalassemia. Most people know about it. And if somebody is like thalassemia minor, if both the couples are thalassemia minor, there is a chance of a thalassemia major baby. And we all know very well that thalassemia major baby cannot survive for a long, and frequent blood transfusions are needed for these kind of babies. So even government has instructed that this kind of baby should not be born and everyone should be screened during pregnancy. So depending on the genetic factor, we have to counsel her, and if there is a big genetic issue is there, then in that case she can go for a donor egg.
In our previous section, we discussed about the uterine anomalies or uterine problems. So is there any role of a pre-IVF hysteroscopy? What do we do in those hysteroscopy?
Definitely, if IVF is getting planned and already there is a failure, we can do a pre-IVF hysteroscopy. We should do to look out for small fibroids, maybe look out for the uterine cavity, how is the size of the cavity, or any other septum or something is present, and if it is there, that has to be addressed. And even if there is a difficulty in embryo transfer, suppose there is a cervical stenosis, then in that case also we have to find out.
Any small polyps found during an pre-IVF hysteroscopy, they need to be removed because they can act as a foreign body and act against the embryo transfer. It impedes the process of implantation. If there is any addition of any form, measurements or any degree of addition in the cavity, it has to be removed. If there is a septum, even if it is a subseptate uterus, then also we have to remove that septum. And while removing the septum, we have to be very careful. We do not cut it with energy source. We have to cut it with a cold knife or a scissors only. If there is a T-shaped cavity, the cavity is narrow, or there is a lateral additions, then we have to do a lateralization incision. We have to do a cavity enhancement thing. And like she said, if there is a cervical fibrosis, patient has undergone multiple DNCs in the past, there is a chance that at internal house there may be a narrowing. So we have to put a small nick and make the cavity void. We do not touch the ostia at this point of time because we are not required about the ostia. And also, most important thing, we look at the endometrium, how it is looking, whether it is pale or it is yellow, or it is, if it is pale, then there are chances that there may be an endometritis. We take that endometrium sampling, send it for a culture sensitivity, and whatever culture sensitivity reports gives us, we will give the antibiotic 3 weeks, 4 weeks before the transfer. So these are the endometrial interventions which we have done. Now we are coming for a next cycle transfer. What do we do which can improve the chances of success next cycle and which wasn't done in the previous cycle? What do we do in the preparation aspect?
In the preparation aspect, already we have spoken about all these things. So we have to go.
Age we cannot change.
Yes.
The embryo quality, if the AMH is on the lower side, can we do anything for the embryo oocyte quality?
Yes. So now you are talking about a fresh new cycle.
Yes.
Yes. So in the fresh new cycle, we have to, before actual starting the stimulation, at least 4 to 6 weeks of supplements can be given for age, like for AMH, for improving the quality of oocytes. We can give DHA, it's a good component. The tablets are available in the market. We have to give folic acid, vitamin B12, vitamin D, which patient was already earlier taking, low dose aspirin. Then we can do good antioxidants to decrease the autoimmune factor in the body. We have to correct thyroid. We have to correct her blood sugar levels. Even insulin resistance, if it is there, she might have borderline high blood sugar levels, which needs to be corrected. We have to ask her to reduce her weight. At least 10% weight reduction we are talking about. Because without doing all these things, if we directly go for a fresh cycle, again the chances of failure is going to be very high. So we have to go step by step. We have to do even for partners to improve their lifestyle, reduce stress, good diet, antioxidants, and if sperm DNA fragmentation test is positive, then accordingly the lifestyle and good antioxidants to reduce the DNA fragmentation.
What we have found in our practice, coenzyme Q is very, very, very potent antioxidant along with melatonin. It improves the quality of both oocyte and the sperms, and it acts as a mitochondrial level at the molecular level. You said stress, reduce stress. It is a word which is easier said than done. Tell our viewers how to reduce stress. What are the practical things they can do to reduce stress? Is there any tablet which is available which can reduce the stress?
It is easier said than done. Very rightly said. Because see, already the female is under a lot of stress. There is a lot of social pressure and stigma attached that she is not conceiving and she has not delivered. And on top of that, we are asking her to reduce stress. But what to do? It is the fact of the matter that stress is going to be one of the reasons for her failure, for her hormonal levels. So here good counseling is needed. We have to counsel her that this is not, she is a wonderful lady. This is not the end of it, and she has to take it slowly. And she has to indulge in some anti-stress activities, like some hobbies or some activities which makes her feel good. A feeling of positivity comes in. Sometimes I just ask these housewives to involve in some part-time play school where a lot of kids are there. So a lot of positivity will come to them. Or some hobby where they can indulge and they can just be themselves, which they have not done all these years. They should involve themselves, and they can go for some small vacations or trips or some outings. And again, the deep breathing exercises, the yoga is going to make their body very flexible. Again, they can involve themselves in some mild sport activities they can do. Antioxidant supplements we are already giving, and the diet. Here they have to be counseled. That is not only for IVF time, even in pregnancy also they have to take good healthy diet, colorful rainbow diet, we talk about it, lot of vegetables, the fruits, the low sugary fruits, and the good seeds and the nuts.
See, I personally believe that early morning walking is the best form of stress relieving exercise. How practical it is, I don't know, but if they somehow can incorporate early morning, I mean 4:30, 5 o'clock, 6 o'clock walking, stress reduces fantastically well. Walking releases endorphins and dopamine, which are happy hormones. Along with that, like it is said, empty mind is a devil's workshop. They need to keep themselves busy. They do not need to keep themselves thinking every time why I am not getting pregnant, because that will unnecessarily increase the stress levels. Plus, magnesium supplements have also been found to reduce stress fantastically well. Magnesium can be found in nuts and seeds of any varieties, badams, the pistas, the walnuts, the chia seeds, all those kind of things. But along with that, we can top it up with the supplements also. Swimming is also a very, very good stress relieving exercises. Plus, the couple is very, very important. They have to think as one. Most of the couples who come to me, the moment the semen report comes normal, he says, "Has, meri problem nahi hai." That should not be the thing. The problem is ours, not mine and hers. So it should always be like that, and they should always be supportive of each other in whatever they do. Is there any role of any immunomodulatory treatment in an IVF next time?
So nowadays, this topic is coming especially for the autoimmune problems. The immunomodulatory treatment is available. Many IVF specialists, before starting the cycles, before actual transfer also they are giving, even post transfer also they are giving. And there are like these PRPs are also done to improve the endometrium and the egg qualities.
There are plethora of things which can be done, right from the steroids to the low molecular weight heparin to the intravenous immunoglobulin to intralipid emulsions to aspirin to intrauterine SCGs. Everything can be tried, but it has to be individualized. A doctor has to be kind of expert in those things, and they can be tried. There is nothing harm in, but for most of them, the Cochrane data says that the results are not very, very good. I mean, trying can be done, but the results are not very, very good. They can be tried or they cannot be tried. Any role of atosiban injection before IVF transfer?
Yes, atosiban injection is actually a oxytocin antagonist. So to avoid the contractions of the uterus, this injection can be given maybe 1 to 2 hours before actual embryo transfer. Because when embryo transfer is happening, if uterine contractions happen, the implantation failure will happen. So to avoid that, this injection is available, although it is little costly.
At the time of embryo transfer, because lots of estrogen has been given to the uterus, estrogen increases the oxytocin level in the body. Oxytocin leads to the uterine contraction, and that has been theorized, or that has been proposed as one of the possible causes of a implantation failure. So if we give a oxytocin antagonist, which is called as an atosiban, they may theoretically reduce the chances of implantation failure. However, as she rightly said, it is very, very expensive injection, and again Cochrane data is not very convincing of it. I normally give cheaper things like pyroxicam tablet, which again acts on the same modality, but it is a relatively cheap tablet. Any role of endometrial scratching before the IVF cycle next?
Yes, endometrial scratching is a minor procedure where before transfer we are trying to scratch the uterus with a very minute thin cannula, or maybe a IUI cannula, or maybe embryo catheters kind of thing. And this usually the hypothesis is this will increase the vascularity in the endometrium, and if somebody is undergoing ERA, it's kind of a scratching procedure.
You discussed vitamin E, you discussed pentoxifylline, you discussed L-arginine. Why do we give these molecules before IVF?
All these are vasodilators, and they increase the blood supply in the uterus and ovaries, which are the structures we are trying to target. Uterine artery resistance, the arteries which are supplying the uterus, if they have a very high resistance, whatever stimulation or whatever injections we are giving, they are not reaching up to the uterus or not reaching up to the ovaries. To dilate the blood vessels, to promote a good blood flow and to promote a good soil, we are doing all these things.
What is the role of probiotics either orally or vaginally before or during IVF?
Probiotic, prebiotic, this is coming up in a big way. This microbiota of the body, it also have a very important role in IVF, a good digestion, a good vaginal flora. So yes, we can add on these supplements, and again we have to give in more and more patients and see how they are working.
Lastly, can an IVF failure patient conceive naturally?
Yes, IVF patients, IVF failure patients, most of the time they are frustrated, there is a state of hopelessness, and they just tear their files and throw away, and they don't want to do anything. And when all the hope is lost and they have left it, that's the time they come with a pregnancy test positive. So yes, they can conceive naturally.
All I would say that for a pregnancy you need a open fallopian tubes, few counts in the sperms, semen test of a male and few eggs left in the ovary. As long as they are there, the hope is always there. And we have seen many patients who have previous IVF failure and they have conceived naturally. So this was our segment on IVF failure. We have discussed in detail almost all the topics. Still the individualization of the case needs to be done. For any comments, for any suggestions, kindly send to us. How you like the video, please like, share and subscribe to the channel. Thank you.